Are we live? Yes, we're live. Okay, great. Hello, students. Thank you for being with me all semester. Thank you so much. Shout out to Brighton Stratton College, all my students at the Racine campus, Wauwatosa campus, and then the Bayshore campus. Thank you for a great first semester. I know that I'm new to teaching, but this first semester is so memorable. I'm so thankful and so proud of everyone for studying so hard. You all are going to become great nurses, and if you ever need stress relief or you want to come study with me at Way of Water Arts, make sure that you look me up on wayofwaterarts.com. Check out my YouTube channel. Have your friends and family subscribe, please. Thank you so much. Like the video, comment, do all that good stuff so I can continue to make videos and be successful. So thank you very much. With that being said, let's get into our final review. We're here right before Christmas. We're at the end of the semester. We studied eye and hearing disorders, which was chapters 25 and 26 in your book. And then we went over musculoskeletal disorders, which was chapters 31 and 32 in your book. So getting right into it, let's start off with osteoporosis. Now, when we're talking about osteoporosis, we know that there is, the way the body regulates calcium in the body is it breaks down existing bone tissue, allows calcium to circulate freely in the vasculature system, and then we build calcium back into the bones to build them up. So we're constantly having this balance of breaking down of bone tissue and then rebuilding bone tissue. Now, as we age, we know the age-related changes that go along, specifically with osteoporosis, is that sometimes there's too much breakdown of bone and not enough reabsorption. We know that vitamin D plays a significant role in helping bone to be rebuilt. So for our older folks, the age-related changes are the bones become more brittle, they become more porous, such as in osteoporosis. So that puts them at risk for fractures. So with our older population, we want to make sure we're doing safety interventions, doing our best to prevent falls so that they don't break a bone. And we know that when the elderly break a bone, there could be the side effect of death because of a fat embolism that gets lodged in the heart or lungs, something to that effect. So definitely very important to review the nursing interventions of osteoporosis. What are some of the risk factors for developing osteoporosis? We know that after menopause and after andropause for men, the hormones are a little messed up. They're not releasing like they should. There's a decrease in hormones. So we know that that puts people at risk for developing osteoporosis, is that hormonal imbalance. We also know that sedentary lifestyle contributes to that. People who don't incorporate exercise into their daily life, they are at risk of developing osteoporosis too. We know that smokers, drinkers, nicotine contributes to bone loss. So some of our teaching should be guided towards helping them stop smoking, increasing calcium intake in their diet, and then also teaching them that they should develop an exercise program, maybe a light weight-bearing exercise program such as Tai Chi, Qigong, yoga, meditation, all great things. So, when we're talking about vitamin D, very important to know that we can supplement vitamin D with a vitamin, using vitamin D as a vitamin, supplementing that. And then also we know that sunlight tends to help us absorb vitamin D and then allow calcium to be rebuilt in our bones. So important to know vitamin D and how that plays with calcium Getting into osteomyelitis. When I talk about osteomyelitis, that is an infection of the bone. And anytime someone breaks their bone and it's an open fracture where the bone is actually sticking through the skin, we know that they are at risk for developing osteomyelitis. People who have been in a motor vehicle crash and they have a severe fracture of one of their bones where the bone is just basically broken in several spots. One of the surgical interventions for that is to use an external or internal fixator. And basically what that does is we insert screws, rods, whatever we need to insert into the bone to get it back into its shape. Then we use pins in an external fixator which keep that in place. So the external fixator is over, let's say they broke their leg, the external fixator is over the leg and it has pins that go through the skin and go into the bone. We know that people are at risk of developing osteomyelitis because there's actual open areas right there leading right to the middle of the bone. So very important that we teach our clients how to properly care for the pin sites. And usually the doctor or healthcare provider will provide orders on how to provide that skin care. Usually it's a mixture of half hydrogen peroxide, half water, and then they clean around the outside of those pin sites. Some of the symptoms that we want to teach our patients to look for in the development of osteomyelitis is obviously it's an infection of the bone, so we want to look for high fever, increasing pain that is unrelieved by narcotics. Typically when someone has a broken bone, if they're in pain, we can give them narcotics. If it's a typical fracture, the pain will usually be lessened. However, if someone is developing osteomyelitis, we can give them narcotic pain medicines and it probably won't help decrease the pain. So definitely know that pain that's unrelieved by narcotics could be a sign of osteomyelitis. What are some other things? Purulent discharge. It is normal to have some discharge from the pin sites. A healthy discharge would look, slightly red, like plasma, serosanguinous. However, when we start to get into like yellow, green colors of discharge, purulent drainage, we know that that can also be a sign of osteomyelitis. So, also, with when you have an external fixator in place, someone who just broke their leg, obviously there's gonna be some swelling there. However, what we want to be aware of is swelling that's beyond the normal swelling. So extremely, it would be extremely painful. It would be really red, really swollen. Those are signs of osteomyelitis. And we know that with high fever, sometimes patients will experience chills. So that's also another sign, high fever with chills. As we're talking about fractures, we definitely want to talk about traction. And one of the more common forms of traction is Buck's traction. And when we talk about Buck's traction, that is basically just traction that they're using. They use traction if a patient can't have surgery right away, but they need it. Typically, they will put them in traction for a short amount of time until they can get surgery for that patient. Although there are some cases where traction can correct the fracture or dislocation. However, you'd have to, the traction will be for a couple days, maybe a couple weeks, and that can be a little cumbersome. So Buck's extension traction, they basically put like a soft, I don't know if we call it like a boot, but basically a soft boot, and then we're gonna be applying traction to it. So let's say that their leg is what's being tractioned. There'll be a soft boot around here. It's not really a cast, it's more just like an outer shell of some sort. And then it'll be connected to some weights at the end of the bed, and it'll provide that stabilization and that traction so that It'll keep it in alignment. So Buck's traction is also known as skin traction. One of the key things we want to look out for is with that foot, we want to make sure to reduce the pressure points, because we don't, especially if they're going to be in traction for a couple weeks, we want to make sure we're looking at the heels, the bony prominences of the ankle, the foot. We want to make sure that we're doing good daily skin assessments to notice any increased redness or breakdown. We also want to make sure that their foot is not being in contact with the footboard of the bed. So even people who aren't in traction, if you ever see someone's foot pressing against the footboard, that is a risk for skin breakdown and pressure ulcer development. So if you ever see someone with their foot against that bed, and people with Buck's traction, very important too, that foot isn't coming into contact with the edge of the bed. So we'll have to reposition it if it is being in contact with that footboard. Also, we know that skin traction is used to try and provide stabilization, but also treat muscle spasms. Sometimes when people break a bone, the muscles that are surrounding those bones have been disrupted and they tend to spasm. And those spasms can cause a lot of pain. So traction does help with controlling the muscle spasms that are associated with a fracture or break. We want to make sure that the weights are hanging free on the end of the bed. We don't want to mess with those or tug on those. Going along the lines, sticking along the lines of fractures, anytime that someone has a fracture and we apply a cast or a brace of some sort, we want to make sure initially that the cast is not too tight. So what are we going to be looking for? We look at the pulse, the capillary refill. We ask them about tingling and numbness. So if the cast is too tight, let's say the cast is around my arm, you want to examine the skin, assess the skin, and make sure that that cast isn't too tight, that it's cutting off circulation. When it is too tight and it is cutting off circulation, it can manifest as tingling and numbness, diminishing pulse of the affected extremity. One of the words we didn't go over in class is poikilothermia. So that's Poikilo thermia. Poikilothermia. That is basically just cold to touch. So if someone has poikilothermia, their fingers are cold to touch on that affected extremity, that can be a sign of compartment syndrome. And then also pain that's unrelieved by narcotics. So obviously someone who breaks their arm, they'll have pain, but if that pain is not relieved by narcotics, you may want to assess further and make sure that they're not developing compartment syndrome. We know that capillary refill normally should be less than 3 seconds. For our older folks, capillary refill can be a little extended beyond 3 seconds because of the diminished flow. But if someone has a capillary refill that's greater than 5 seconds, you definitely want to immediately act upon that. So always assessing capillary refill for people who either have a cast or some kind of just had a surgery, such as a carpal tunnel surgery. When we talk about people with broken hips, in my time in long-term care facilities, one of the biggest and scariest things was a hip fracture. Because when our folks fell and developed a hip fracture, it can really throw things off. And that is one of the main things that can contribute to death is that hip fracture. So someone who does survive a hip fracture has a surgery. One of the things that we want to teach people with hip surgery, is we don't want them to extend their hip beyond 90 degrees. So if I'm sitting on a chair here, let's pretend this is my hip right here. we don't want to have them go beyond 90 degrees. So when they're sitting down on a toilet seat, if that toilet seat is too low for them, that when they sit down, their hip gets elevated above 90 degrees, that is bad. We need to incorporate a seat riser. When we're incorporating a seat riser on the toilet, that prevents the hip from going beyond 90 degrees. That is definitely something we want to avoid, because if you put that hip, extend it beyond 90 degrees, it puts the patient at risk for dislocating that fracture. We also want to teach them never to cross their legs when they have that hip surgery. A lot of times we can use what's called an A-frame and put that between their legs so that it keeps them in alignment and prevents them from crossing their legs, which we absolutely don't want them to do. Getting into vision and hearing disorders, we definitely know that an abnormality with vision would be a sign and symptom of a vision disorder would be eyes that tire easily, patients who are reporting burning and itching in their eyes. If their eyes start to get red, that can be a sign of allergies or another eye disorder. One thing that is important to know, and I don't know that we talked about this much during the semester, when we talk about exophthalmos, that is a bulging of the eyes. The underlying problem of exophthalmos is not the eyes itself, it's the thyroid. And when the thyroid is hyperactive, it tends to lead to exophthalmos. So the primary problem with exophthalmos, yeah, the eyes are bulging, but the primary problem is a thyroid issue. Not the eyes necessarily. We know that with age-related changes with the eyes tend to become, they tend to have less water in them, so the lens of your eye becomes less elastic, more prone to developing cataracts. Know that presbyopia is where you put something in front of them, and when you hold it there, as the eye ages and changes, they have to put that print further and further away. So they lose their ability to see things up close. They have to move things actually further and further away for them to see it clearly. We know that with age-related changes of the eyes, the cornea flattens. That can increase astigmatism. And we also know that with the water loss, the eyes tend to secrete less tears and less fluid, so that can lead to drier eyes. That can lead to infection of the eyes. With skin changes with our elderly, the lower eyelid can start to droop. The upper eyelid can actually start to droop so much that it obstructs vision. And when you have this eyelid that comes down like this, the patient is much more at risk for dry eyes, developing infection, and having like that crusty discharge on their eyes because it's constantly being bombarded by whatever, maybe smoke, irritations, things like that. So also the eyelashes start to decrease. We know that eyelashes are a protective measure to help trap foreign particles from getting into that eye. So know those age-related changes. Also age-related changes with the hearing. The eardrum becomes less elastic. Those small bones inside the inner ear tend to become a little stiffer. Your cochlea may become dysfunctional. The eustachian tube won't be able to equalize pressure. Hearing loss can ensue. Loss of balance when there's inner ear disorders can ensue. So people who have hearing disorders, we definitely want to have safety measures that are in place to help protect them from falls due to loss of balance due to that inner ear disorder. Also safety for people who are losing vision. You want to make sure that the walkways are clear, that they have a direct line to the bathroom if they're able to get up on their own and ambulate. Make sure that there's nothing, clutters out of the way so that they don't trip and fall or stub their toe or something like that. Give nursing interventions for visually impaired people. We still want to encourage them to be as independent as possible. That includes feeding themselves. So the correct way to orient them to their food is to place the food in front of them, obviously explain to them what foods are there, but then when you talk about orientation of the plate, you want to think of the face of a clock. And so with that plate in front of them, put yourself in their position. You think at 12 o'clock, I have potatoes. 3 o'clock, there's vegetables. 6 o'clock, there's your meat. 9 o'clock, there is the dessert. So lay it out like that. Lay it out as a clock. Give them directions like that. When we're talking about glaucoma, we know that glaucoma is an increase of intraocular pressure within the eye. And that can be due to things like high sodium diet, too much fluid on board, heart failure. That fluid can build up in the eye. In your eye, there's a balance of fluid that is being produced and then fluid that is coming out of the eye. So there's this constant flow of fluid in, fluid out in the eye. However, if there's too much fluid going in and not enough fluid going out, then we know that the pressure within the intraocular space can increase, leading to glaucoma. And we know that glaucoma typically manifests as bright, oh boy, there's embers coming out from the fire. With glaucoma, one of the signs is bright rainbow colors with halos around them. That's important to know. Peripheral vision can be affected. To diagnose glaucoma, you'll go to a eye doctor and they'll do a little puff of air in your eye and it'll give them a pressure reading. We know that people who have diabetes are at much increased risk of developing glaucoma. So someone who has diabetes, starting at the age of 35 years old, if they're a diabetic, we are telling them they should have eye exams every 1 to 2 years. So after 35 years of age, if they have diabetes, they're at an increased risk of developing glaucoma. We're educating the patient, you need to see an eye doctor every 1 to 2 years to make sure that we can manage, look out for things like glaucoma. We also know that African Americans are at much more risk for developing glaucoma. When we talk about retinal detachment, remember when I talked about retinal detachment, it can manifest as the patient saying that they're either seeing dark floating spots or feel like a shade or drape has been drawn on their vision. So their vision gets narrower and narrower and narrower. Also, flashes of light. So flashes of light, black spots, and then feeling like that curtain is being drawn can be a sign of retinal detachment. And retinal detachment can manifest from things like an accident or just constant stress on the eye. But with traumatic accidents, such as like high speed motor vehicle collisions, if someone's being jarred like that, that can actually start to separate the retina and detach it. So important to know about the signs and symptoms of what a retinal detachment may be. People who have eye cataract surgery, we want to teach them that their vision is going to be impaired for a little bit. It's going to take some time for their vision to get clear. So we want to make sure that they're being safe and teach them to have somebody with them. They shouldn't be driving. They should have somebody with them assisting them walking so that they don't fall. Whatever side was they had the surgery on for their eye, we want to teach them not to lay on that side when they're sleeping, because when you lay on that side, it can increase the pressure in there. We want to teach them to do They can resume some activities as long as those activities are not high stress, high impact activities. We definitely don't want them out doing gardening work, mowing, or weed whacking immediately after their surgery. So. Also, one thing we want to teach people who have had an eye surgery is we don't want them straining when they're going to the bathroom. So very important that we incorporate a stool softener or tell them to increase their fiber. But yeah, definitely if they're going to be straining, we want to incorporate a stool softener so that they can pass their stools much easier and they don't have to put so much pressure like the Valsalva maneuver, straining to release their bowels. We know that with age-related hearing changes, we know that an age-related hearing change called presbycusis is where the ability to hear starts to decrease, and that's due to age-related changes such as the decreasing elasticity of the eardrum, the tympanic membrane, or ossification of those small bones inside their ear. That term is presbycusis. Very important to, when we're talking to people who have hearing problems, we want to sit at them eye level, speak clearly at a moderate pace. We don't want to be shouting into their ear that is affected. We definitely want to minimize distractions, so that can include turning off the TV, closing the door, pulling the drape closed so that we can have one-on-one focus with that patient who has that hearing loss. We want to enunciate clearly, use simple sentences. You definitely don't want to be chewing gum or speaking too quickly and rapidly. When we talk about flushing out the ear, remember I told you that with our older folks, the earwax tends to become a little bit harder. It doesn't come out as easy. We never want to stick anything inside their ear to get things out. What we do utilize is the earwax softener drops. So we put the drops in their ears for a couple days. On the final day, we flush with tepid or lukewarm water. Make sure to drape the patient with towels that can absorb the water that you're going to be flushing the ear out with. If the patient, while you're flushing the ear, if the patient starts to say that they become nauseous and nauseated and feel like they're going to vomit, you want to stop flushing the ear immediately, and then definitely give them some time to recover. And if the nausea and vomiting don't go away, call the healthcare provider, see if you can get something to combat that nausea and vomiting. When we talk, very important to know one of the ear disorders called Labyrinthitis. And basically, Labyrinthitis is an inner ear disorder where there is extreme pressure in the cochlea. There tends to be mucus that builds up in that area. The patient can become very nauseous, have vertigo, which can cause them to lose balance. So very important that patients with labyrinthitis, that they are safe and that they ask for help when they're walking or transferring. Getting into Menieres disease, that is a little similar. Menieres disease tends to manifest as tinnitus, ringing in the ears, hearing loss, headache, a sense of fullness in the ear. People with Menieres disease, it's an inner ear disorder where if they move their head too fast or if they get up suddenly, it causes extreme vertigo and feelings of nausea and vomiting. So that contributes to poor balance, which can contribute to falls. One of the things with Menieres disease is there tends to be too much fluid in the ear. So we want to teach patients to restrict their sodium, Maybe we might have to restrict fluids, and the hope is that by restricting sodium, restricting fluids, that'll help balance out the excess fluid that's in their ear. So we can treat someone who has an acute exacerbation of Meniere's disease. They have extreme vertigo. One of the interventions we can use is to give them a PRN dose of atropine followed by a dose of diazepam. During the acute attack phase of Meniere's disease, giving these PRN medications can definitely provide relief for the patient. One of the things that we don't want to do is make sudden loud noises, turn on the bright lights. Those can all exacerbate an acute attack of Meniere's disease. Getting into rheumatoid arthritis, we know that rheumatoid arthritis tends to be an autoimmune disease where the body's attacking its own joints. Some of the interventions that we can do for that is teach patients to do gentle range of motion exercises 3 to 10 times for each joint. We definitely, if there's too much inflammation going on, we want to be able to give them maybe a medication first, like an NSAID, to help decrease that inflammation. Then they can do the range of motion exercises. If they are doing the range of motion exercises and it's too painful, it's too inflamed, we wouldn't encourage that at that point. We'll give an anti-inflammatory, wait a little bit, and then reapproach, and then inquire about if it's comfortable enough to do those range of motion exercises. If someone who is on a regular schedule of exercise and they have rheumatoid arthritis, if they miss a day, we definitely want to teach them that if you miss an exercise day, don't do double the next day, because just resume your normal schedule, do the 3 to 10 times for each joint. Don't do double the work, because then the next day you're probably going to suffer before doing double the repetitions for that. So getting into osteoarthritis, very important that we teach them gentle range of motion exercises that they can do, weight-bearing exercises to help promote bone strengthening and muscle strengthening. So definitely our Tai Chi, Qigong, yoga, meditation, those are excellent for people with osteoarthritis. Okay, well, I think that is about it for our review here. Let me just go through this real quickly and see if there's anything else. So the rest of the tests will be things that we've gone over during the whole semester. Important to know about treatment for bone cancer. You know, the people will become immunocompromised. People who are receiving external radiation to treat bone cancer, they may have the provider or healthcare provider or nurse who's treating them with the external radiation may put temporary marks on the skin, on the place that they're treating. And sometimes it is a tattoo, a more permanent marking, or just like a permanent marker that tells them the exact spot to put the radiation to. So we teach our patients, don't try to wash off those markings if you're getting external radiation to treat bone cancer. Those markings are for the techs who are administering the radiation so that they can line up the exact spot that they need to treat, because people are going to have to get several treatments of radiation to treat that bone cancer. So you never want them to wash off those markings, keep those on. There's a little bit here about right-sided heart failure versus left-sided heart failure. Make sure you remember about that, the signs and symptoms. TB, there's a question here about active TB. Respiratory acidosis, research on that. And yeah, that's about it. So thank you guys so much for a great semester. I hope the final review is helpful. Once again, you guys are going to make great nurses. I'm so proud of you. Once you graduate LPN, give yourself a year or two to adjust to your new role, and then get your butt back in school and go on ahead and continue your education, because through education comes empowerment. And I remember in my early schooling, it was hard for me to accept that I was going to have to go back to school. So give yourself time to adjust. You guys are going to make great nurses. I'm so proud of you. Make sure that once you are that nurse, that you come back to Way of Water Arts. You can come train with me, watch the videos, but make sure to incorporate all semester long. I've been teaching you guys about Qigong, how to utilize Tai Chi and meditation to manage your own stress, but then also to be used as a tool for your patients also. I think through the whole semester, a nursing intervention for almost most of our diseases is to have stress reduction, and being able to manage your stress through meditation, through deep breathing, abdominal exercises, through Tai Chi, enhancing your balance. Very important. So make sure you come on back, see me at Way of Water Arts, and then also make sure that you're getting your friends and family to subscribe to that YouTube channel, like and comment on those videos, and thank you very much for a great semester. Annyeonghaseyo! Thank you so much, students.